Now, the Stop Stockouts Project, in partnership with Ritshidze, has released a report that deals with the contraceptive stockout at health facilities. The previous report had found that contraceptives are prevalent stockouts in some parts of South Africa. Joining us to tell us where this problem is common is Dr. Jess Rucell, who's the principal from the Just agency. Dr. Rucell, thank you so much for joining us this evening. And I guess if you could just start off by telling us a little bit more about this report and the findings.
Thank you so much. So the Stop Stockouts Project brought me on board to investigate the relationship between the supply chain and contraceptive stockouts. Since the project had been collecting data and analyzing it in relation to stockouts in general, it found since 2022 that the main medical supplies that have been stocked out are contraceptives across the country. And they wanted to understand what is driving this. Why is this happening? What is the relationship between the supply chain? So we conducted this investigation, and what we found, we focused on three particular provinces: the Northwest, KwaZulu-Natal, and the Eastern Cape. And we did that because the previous research had showed that they had the worst situations when it came to contraceptive stockouts across the country. So we wanted to investigate in particular what's going on in those provinces. And we were surprised by some of the findings, I must be honest, that we did not anticipate that the poor national procurement planning at the national department level has been the main driver of the depletion of contraceptive stock between 2015 and 2020. At the provincial level, there are also drivers that we uncovered that are ongoing and are not unique to contraceptives, but affect contraceptives as well. At the national level, what we found out was that poor planning, in this case resulting from the department not anticipating a depletion in national stock because the state donated contraceptive methods to a 3-year international randomized clinical trial. This clinical trial, when it released its results in 2019, was the headlines of every single newspaper, including the New York Times, all over the world, because it was claiming to investigate the relationship between acquiring HIV and injectable contraceptions. And so this was part of the reason that the state did donate contraception to it, because it was such a national priority for South Africa to understand the potential of these outcomes. However, the department did not anticipate that manufacturers would stop supplying in anticipation of the ECHO trial. They would stop manufacturing, in anticipation of the ECHO trial, showing that, in fact, injectables do contribute to the acquisition of HIV. That wasn't what the trial found. However, manufacturers had already stopped creating the supply. The department also told us that because of the lack of injectable supplies, this was a knock-on effect to other contraception. And this really has drawn out for 5 years in terms of the stock that we have seen depleted across the country.
So, Dr. Rucell, not to be the mascot of doom and gloom and anything anti-government, can we blame these shortages of contraceptives on government then, if it's because of a lack of planning and poor planning?
I think we have to, because the government is accountable to, foreseeing risk, right? This is part of what procurement does. This is what the Department of Health and the procurement department that is in charge of medical supplies and commodities does. This is what all of the health department managers at the depots meet with national government about on, I believe it's a quarterly and annually basis. So, you know, it's not just the findings of my research in this report released by the Stop Stockouts Project that's saying this. Existing literature has already identified that poor forecasting and planning is an issue with stockouts in general. So, you know, it was very insightful for the Department of Health managers and senior officials that we interviewed to inform us of this. So, in fact, this does rest on their watch, and I think that more transparency and more accountability needs to be pressured for, because stockouts of contraception across the country for 5 years is a very serious matter. It's not that only the national departments are responsible for these stockouts. At the provincial level of governance, we also found serious problems that are elongating and continuing to drive the stockouts. For example, what we found was incompatible electronic management systems, which doesn't allow provinces to easily track invoices and payments. And then there becomes a backlog in payments because of the paperwork issues, and them having to go from primary care, district hospitals back to the depots in order for payments to be made to the manufacturers and the suppliers themselves. These were particularly serious issues that we found in all three provinces, the Northwest, KZN, and the Eastern Cape. But particular backlogs were found in the Eastern Cape.
And also earlier you mentioned, you know, the injection as well, the injectable contraceptive. Do you know which other contraceptives are also facing a stockout?
So, like I was saying, these particular stockouts that we identified are primarily of the injectable contraceptions. The 3-month and the 2-month is what they're normally referred to, or petagen. And these were precisely the, you know, one of the main contraceptions that was being tested as part of this randomized clinical trial, the ECHO trial, right? But this is also the most commonly used contraception in South Africa and indeed across the continent. So what happens is once that contraception that everyone is usually on, who's accessing from the public sector, is out of stock, then the nurses and health workers end up offering a different contraception. So the way that the supply chain works is that procurement happens based on an annual tallying of usage. So once you have that depleting because of a stockout 1 year, it's going to influence the numbers of the next year. And once you have, like with any medication, any particular, you know, tool for our health that we're using, once we change from one to another, it's going to affect our health, right? It's going to affect our fertility. It's going to affect the side effects that we're on. And it might even make it so that we don't want to take this new drug. We've been satisfied with the old one. And it just causes all sorts of significant challenges for women users.
And just in closing, Dr. Rucell, as well, do you see the will from the Department as well of Health nationally and in the different provinces that you were conducting this research in as well? Do they understand that what the poor planning has doing and the adverse effects as well on community members?
I think that we still have a long way to go in terms of closing the gaps between the policymakers and the users and understanding the significant impacts for the major decisions that they're doing. I think that we do have a lot of goodwill and interest within the Department of Health, both at the provincial levels. Again, we interviewed senior managers from the Northwest KZN and the Eastern Cape, as well as at the national level. I think that there is a goodwill and interest for the system to function better. But to be quite honest, there needs to be a greater sense of accountability and consequence management. We need to ensure accountability for the errors of poor national planning that has resulted in long-term contraceptive stockouts throughout the country. There needs to be a real actualization of prioritizing gender equality, adolescent pregnancy, and reproductive rights. This means that we need to have defined budgets for contraception and contraceptive delivery, as well as termination of pregnancy. This is not something that we've been seeing. If it was prioritized, we wouldn't be having these challenges. And I think finally what we need is to address the incompatibility of the manual data information systems, basically where people are handwriting invoices and inputting payments versus the electronic methods. Right now, we're still in a process in South Africa of upgrading so that everything is done electronically, and that those are compatible systems, both within provinces and between provinces. That we need to have a real investment in adequate human resources, and that's not happening in terms of pharmaceutical training and procurement planning. So I find that those that we interviewed in all of the provinces were frustrated because they want to deliver the service. They're there doing the work as professionals, professional clinicians and pharmacists. However, they just don't have the resources from the state and really the support that they need. Again, this is going on the back of women and young girls, and this is not acceptable, especially 30 years into what is meant to be a growing equal society where we find ourselves more unequal.
Absolutely. Thank you so much for just sharing your insights with us about this investigation as well, and your time.